Great, thank you so much for having me again. It's nice to actually be here in person, and since the last time I was here, I would say that there have been many emerging infections and pandemics. Before, the last time I was here was pre-COVID. So today I'm going to be talking about kind of local and global emerging infections. Let me just make sure. There we go, I have no disclosures. As I mentioned, we're just going to be discussing a few emerging infections, or ones that are already here, epidemiology, their presentation, diagnosis, and management, and then potentially some other ones as well. We all know what this is. This has been dominating our lives, personally, professionally, for over two and a half years now. But there are other things that are happening in the world as well, as we know. This is monkeypox that I'll talk about today, polio as well, and then we've all heard about tomato flu. I won't spend time on that today, but there's always something coming up on the horizon. Why we are seeing these infections give rise, there are lots of theories. Changes in our habitat, our communication and close proximity to animals, which harbor a lot of infections and transmission to human hosts, and then that spread. We live in a very global community. Things don't stay sequestered in one place anymore, as we know, with shutdowns and travel bans to countries that had COVID early on. It doesn't really change what we see. We know it's going to get in somehow. Deforestation, again, those animal habitats coming closer with human habitats, ocean warming, global climate change, all of those things are contributing to some of the infections that we see that give rise to epidemics and pandemics today. I wanted to just spend a minute talking about COVID. I'm not going to spend too much time because it's not really emerging. It's been here, it's well established. But there are also variants that we know that could be problematic as we move forward with this pandemic. Currently, we're all focused on Omicron, but there are other variants out there globally that could offer clues to what we may see here in the future. Here's kind of the pathogen progression. This is nice from Nature, just showing kind of the variants that we've seen and what is dominating right now, mainly BA4, BA5. And this is from the New York Times that has nice statistics and graphs. As you can see, sort of our surges over time, and really that the Omicron surge most recently eclipsed in number any of the previous surges that we've had. So just a brief update on COVID vaccines. We actually have 4 vaccines, although J&J is somewhat limited, that are available in the US. Most recently, the Novavax, and that's really for people that were afraid of kind of the newer technology and may have been vaccine hesitant in the past, that they might be more amenable to getting a more traditional vaccine. But there hasn't been a huge amount of uptake with that vaccine yet, but it is an option. Then we just had recently the UK approving their variant booster, their bivalent boosters, just before the US did, with each dose containing half of the original Wuhan variant and then half of the BA1 in case of the UK, which did have some human trials that went to investigate its efficacy. And then we have our bivalent boosters that just came and that were just authorized for emergency use by the CDC Advisory Committee for Immunization Practices. We just opened up scheduling this week, actually, and I think today or yesterday was our first day of giving doses. So they're out there, they're in limited supply right now, but we are going to see a robust supply in the coming weeks. And in terms of eligibility, you have to have had a primary series of a COVID vaccine. It doesn't matter what you got previously, but you had to have had a primary series. And then at least 2 months since your last booster, and they're saying 3 months, or at least 3 months or 4 months since your last COVID infection to get the booster. And I think we just all want to be prepared for a coming surge again in the fall for for the infections. And there was just a paper that just came out this week that showed that hospitalization rates amongst those who are vaccinated were a tenth of the rates in people who were unvaccinated during this Omicron surge. So really, even though people have COVID fatigue, vaccine fatigue about COVID, we just need to start thinking about this as a more of a seasonal kind of vaccine potentially, or maybe more than seasonal right now, but that this is going to be with us and we need to have protection ongoing, and it's not just a one and done with your primary series. That's enough about COVID. I wanted to spend some time talking about a different infection that's going around. A 35-year-old man who presented with penile lesions. This was in May, mid-May. He had gone to visit a friend in London in early May, and he had had anal assertive intercourse with this friend and shared a bed and shared a room for a few days. He returned to the US in mid-May and developed penile lesions, initially not painful, then subsequently painful. He went to urgent care and was diagnosed with herpes. He had a swab done and was treated empirically, but the HSV swab came back negative. He went to another clinic as he had no improvement, and he had looked at the news reports and heard that there was a new infection in the UK and said, could I have this new infection? And so when he prompted that, the public health was called, and they coordinated testing for monkeypox, which was positive. These were his penile lesions. That larger lesion was actually multiple lesions that had coalesced. And that's where they initially started. But by the time I saw him, when his PCR came back, he actually had a lesion on his tongue, as well as this is on his ankle, but he actually had numerous lesions all over his body, including his face. So just in terms of the timeline of monkeypox, monkeypox is not new. It's been around for decades. It was actually first discovered in 1958 in monkeys that had been shipped from Singapore to Denmark. The first human case was actually noted in the Democratic Republic of Congo, and then there was sustained human transmission that was noted in 2003. At that same time in 2003, there was actually an outbreak noted in the US associated with prairie dogs, which I guess were kind of trendy pets then, because they're so cute, you can see them, but they actually were co-transported with these giant Gambian rats that I presume are not so cute, but they also had monkeypox. And so there were 53 individuals who had monkeypox infection that was directly transmitted from animals at that time. Then, since that time, there's been some ongoing transmission, but there was a larger outbreak in 2017 in Nigeria involving close to 200 people that were at least identified and across 18 states, and it was thought to reflect maybe a declining immunity from smallpox itself and some increased interaction with animals that were harboring the infection. And that brings us to where we are today, which is our global outbreak since May, when the first cases were reported in the UK. There had been a smattering of cases, less than 10, that were reported in the UK prior to that were all from direct contact in a country with known transmission for monkeypox. So this was very different, and the mode of transmission seems to be very different because it's primarily in men who have sex with men, so thought to be from sexual contact. So this is where we are today. I just updated it yesterday. We're at over 56,000 cases that have been reported, at least worldwide, and the majority of those cases are actually in countries that historically did not have monkeypox. So Europe and US being notable ones in that. The deaths are actually quite low, 18 deaths reported during this outbreak, which is very different than the Nigerian outbreak that was earlier, which that had higher, that outbreaks in the past, which were different clade that had higher mortality rates, up to even 10%. So again, this is just updated in terms of our numbers, and you can see Washington State actually has, for our population, a fair number of cases. And the hot spots include New York, Florida, and Texas and California as well in terms of the number of cases. And this is sort of our weekly trends, and you can see we thought we were going down, but I think there's just a lag in reporting, and so this week we did have a significant number of cases as well. There are new names that were just given by the WHO last month for the variants. We're really trying to get away from naming variants like we did with COVID from the place where they were first identified, and really giving them more scientific names like Clade 1, Clade 2, or Omicron or Delta. And what we're currently seeing here is actually Clade 2b, which is related to the West African clade, which is less mortality compared to Clade 1. It's an orthopox virus. It's in the same genus as variola, which is smallpox, which is why it was concerning at first, but again, like I mentioned, the mortality of this clade is much lower. It's also associated with vaccinia, which is what is used in the smallpox vaccine. There are a large number of viruses in this genus, and there's variable pathogenicity and host range. It's a double-stranded DNA virus. In terms of transmission, it's a zoonotic disease. Rodents are thought to be the natural reservoir, and we know that there's been animal-to-human transmission, as I mentioned with those prairie dogs, but there's also been human-to-human transmission, which is very much exemplified by our current outbreak, which a close, intimate contact with people that have monkeypox has been leading to that transmission, and that could be close contact with bodily fluids and skin lesions. Sex is also a close contact that is happening. And then also some fomites in terms of close contact with contaminated materials such as bedding and clothing. It's also vertically transmitted, so in utero. And then we take respiratory precautions pretty seriously for patients with monkeypox, but it's not very common that we have seen transmission with respiratory droplets. Although it's been primarily over 95% in men who have sex with men, we have started to see some cases in women. This was late last month where we've seen women, and we've also seen children. An infant who had been exposed to someone in the family who had monkeypox. And so we do know that transmission is occurring in households. There are two women that I know of that have been cared for in our system. One had survival sex or exchange sex and was working on the street, and so had probable exposure, multiple sexual exposures. The other woman, we actually don't know what her exposure was. We also know that there's been transmission from humans to animals. This was published in The Lancet just last month, that an owner actually gave it to their Chihuahua. And so there are some recommendations about isolating from pets, which can be difficult, just like isolating from children. So in terms of the clinical course, after an exposure, you can get an incubation period anywhere from 4 to 21 days. It's usually just over a week. And then there can be a prodrome. And not everyone has to have a prodrome, though, but it can be fevers, headaches, lymphadenopathy, really like a non-specific viral syndrome that could be mistaken for COVID or other viruses. And then after that prodrome phase, you can, or even without that prodrome, you can see a rash appear. And they began as macules, and I'll show some pictures about how that evolved. But some of the early reports actually didn't even have rash. One of the prominent symptoms was actually proctitis, and so painful rectal symptoms as their primary manifestation of monkeypox. And the rash can take weeks to resolve. And so here is kind of the progression of the lesion. Starts with a macule, which can be very nonspecific, then a papule, a vesicle. And these are the vesicles are the classic pox lesions that we're used to seeing, pustules. And then what happens is they crust over, they scab over, and we don't consider them non-infectious until the scab completely heals, falls off, and there is healed skin underneath. And this is very similar to what we see with smallpox when we say that people are out of that contagious or transmissive window. This is very different from herpes viruses like zoster and HSV, where once the crusting has happened, we pretty much presume that they're no longer able to transmit the virus. So here are some other presentations that I wanted to show you. This was recently in the Lancet. Cutaneous lesions, but you can also see that there's a subungual lesion. And this is actually the one that's the ultrasound is actually an abscess, which we are also seeing in some patients, particularly immunocompromised patients that come in. This was just published from the UK experience in the New England Journal of Medicine, and you can see the variety of lesions that are here, including cutaneous lesions, particularly around the mouth there, or the tongue lesion in D, but the F, G, and H are the mucosal lesions that you can see, which may not signal you to monkeypox right away based on their appearance. And then again, perianal lesions here that we've seen as well. What about asymptomatic monkeypox infections? We always worry, with COVID, what was scary at the beginning was that people could transmit the virus in the asymptomatic phase before symptoms started. Is that the case with monkeypox as well? So there were two groups of investigators in Belgium and in France that went back and looked at their sexual health data for patients that were coming in regularly for screening for STIs, and looked at the rectal samples and said, hey, did they actually have monkeypox? And we didn't know. So in the Belgian study, they actually found 4 individuals out of 200-something individuals that had monkeypox that they didn't know about. So pretty low. But actually in the French series, it was a little bit higher. 6.5% of the individuals that had samples that they tested were actually positive for monkeypox with no symptoms. What does that mean for transmission to others, even when they're asymptomatic? We don't know. There are mimics. In June, after Pride in Seattle, many people started freaking out. Could this little bit of rash be acne, or could it be monkeypox? There was a lot of concern that we were hearing, but there are some mimics, because as you can tell from the previous pictures, it can be indistinguishable from herpes viruses, syphilis, molluscum, condylomata lata. So having that clinical suspicion for testing is really important, particularly during an outbreak like we're having. Good news is that overwhelming majority of individuals do well. The case mortality rate is very low. As I mentioned, there are 18 cases out of the over 56,000 individuals worldwide that have had mortality from this. There is more severe disease, though, with people that are immunosuppressed and in children. And there are some complications like bacterial superinfection, scarring, which patients are concerned about, as well as some other systemic symptoms that can happen, although rarely, with this clade. So testing. Definitive diagnosis does require PCR testing. Initially, our state lab was the only game in town, and you had to get approval, and so I'm not sure if anyone had to do this. There was a lag. It took days to get the results back, but now many commercial labs are offering it to allow for improved access to testing, and the turnaround times do vary. Our UW Medicine lab does offer it with a turnaround time of 24 hours or less. But as I mentioned, you have to consider the diagnosis to do the testing and to swab. You do not need to unroof the lesions. They're teeming with pox, so you can just swab the lesions. What about treatment? This has also been a challenge for anyone who has tried to do this. Initially, it was quite difficult. To get tecovirimat or TPOXX, which is an antiviral. It actually works across orthopox viruses and was FDA approved for the use for smallpox, but it's under an investigational drug category for the treatment of monkeypox, so it does require treating it like an experimental drug and getting consent and working with the CDC to be an authorized prescriber. The data with this drug for FDA approval were solely based on animal data in macaques and healthy volunteers without any monkeypox or smallpox who were just taking it for safety or for acquiring safety data. It's really not a lot of information prior to this outbreak on its use. There was one patient that received it through this patient 7 in 2021 who had acquired it abroad and had some improvement, and that's pretty much the only human data we really had prior to this outbreak. But we do have some more real-world data now. This is from UCSD that was published in JAMA Open Network that looked at 25 patients. They all, 9 of whom had HIV, and a lot of them did have systemic symptoms, and 100% of them had pain, which was their indication for treatment. And the outcomes, 10 patients, 40% had complete resolution of all of their lesions with healing of their lesions in 7 days. No one discontinued therapy. They tolerated treatment quite well. There are other treatments that I won't go into too much. Cidofovir, which is FDA approved for CMV. There's no real data in humans for use against orthopox viruses. Again, it's in vitro and animal data. Cidofovir, which is FDA approved for smallpox. Again, no data in monkeypox. And orthopox virus is only in vitro and animal data. And then vaccinia immune globulin, which is currently licensed for treatment of complications from vaccinia vaccine, which is a live vaccine that I'll talk about, but really no data for use in the treatment of monkeypox, and this is actually kind of hard to acquire, so we are not currently using it in this outbreak. So who to treat? Given that everyone most people do well, I think the main indications have really been for immunocompromised folks, pediatric populations, pregnant or breastfeeding women, people who have really sensitive or atopic skin that could have more scarring or worsen disease, because you could auto-inoculate different places if you're scratching and have underlying skin disorders. So getting that virus under control is really important for those individuals. And then one other really important thing is that we're using for treatment is of the anogenital lesions, because they are painful, to decrease the time of pain and allow for healing of those lesions. And these are the CDC recommendations. Other management, really thinking about symptom management for patients with proctitis, and it's really pain control, or oral lesions with lidocaine or magic mouthwash. The other important thing is isolation, really counseling about isolation, symptom monitoring, particularly with tecovirimat. We want to make sure that people keep a diary of their symptoms. But the isolation period, unlike COVID, where we can say 5 days, then you can come out with a mask for 10 days, there's not really a set period of time, because it varies how long it'll take for those lesions to heal up, scab over, and then the scab fall off to reveal new skin. So we're saying 2 to 4 weeks for some individuals, which is kind of a hardship if you're working and need all that time off. So the 2 vaccines that are available, ACAM 2000, I'll just mention, it's a live replication-competent vaccinivirus. We actually have lots of it, but we're not using it during this outbreak because it is a live vaccine. And honestly, from a patient perspective, it's not a friendly one in that it requires pricking of the skin. So people who have gotten a smallpox vaccine in the past, I have, and it causes the whole point is to cause a local infection with vaccinia to basically create an immune response that's cross-reactive against orthopox viruses. And you have to do wound care to it, because you can spread that live vaccinia, replication-competent virus, to other parts of your body, so you're not supposed to touch it. And there are some myocarditis concerns, and obviously it's contraindicated in certain populations because it is a live virus. So you take a bifurcated needle and dip it into the vial with the vaccine, you get a drop, and then you basically have to jab it in the person's arm 15 times, which sounds really fun, and perpendicular to the skin, and then what you look for is a take, meaning that they will have a reaction, and the whole point, if they don't have a reaction, then they didn't have a take, which means that they didn't likely create an immune response. So as you can imagine, no one would really be signing up for this vaccine when we have a better vaccine available, which is the Jynneos vaccine. It's a live vaccine, but it's actually a replication incompetent virus, so it can't replicate and cause infection from the vaccine itself. It is 2 doses, though, dosed 28 days apart, and it's in much less supply than the ACAM 2000. And you're considered protected 2 weeks after your second dose. There can be some local site reaction, and it is okay to give in those special populations because it's not live. And in terms of how we give it, we were giving it sub-Q, which is what it was FDA approved for, but actually there was an emergency use authorization to allow for expanded access of this Jynneos vaccine to get up to 5 doses out of the vial by doing it intradermally and using 1/5 of the quantity. And so intradermal, similar to a PPD, and you can get more doses out of the vial, and we know from other intradermal vaccines that it's very likely to create a good immune response. And then what you can see here is that people can have a post-vaccine hyperpigmentation that can last for a really long time. And when we're thinking about it on the forearm, this can be stigmatizing because people feel self-conscious about having a reaction that may persist, that is a tell that they had this vaccine and could create some stigma about their risk and judgment. But there was a perspective in the New England Journal that just came out recently that really wanted people to think about why intradermal dosing was a good strategy, not only because we can get more doses, but because when we get more doses, we can offer it to more people and really stop this epidemic, and the fact that it's not an inferior vaccine to subcutaneous dosing. The only precautions with the intradermal, or if you have somebody who has a strong likelihood of developing keloids, then they may have more of a reaction to the intradermal, and it's not, the EUA does not cover patients under 18. The indications for the vaccine right now for post-exposure, so if you've had a high-risk exposure to someone with intimate contact with someone with confirmed monkeypox, then you want to give it, best within 4 days, but up to 14 days if they don't have any symptoms. And then pre-exposure prophylaxis, we're really focusing on the highest risk individuals, so that's currently gay, bisexual, MSM that that are at risk, have had STIs, for instance, or multiple sexual partners that would indicate that they could get monkeypox. And then, as I mentioned, stigma is really important. Many of the patients that I have seen for monkeypox, they are worried that this is being portrayed as a gay disease, and really trying to reframe it that we are all concerned about monkeypox, just like we are concerned about all infectious disease outbreaks, and avoid marginalizing those individuals by using that more inclusive language. Okay, we'll fast forward to another infection. A 5-year-old child presents with vomiting, dark urine, light-colored stool, and jaundice. So I wanted to bring up these interesting cases because I don't know if people have heard about pediatric hepatitis. Initial cases were identified actually in Alabama of 5 kids who had severe hepatitis and liver failure. And they all were found to have adenovirus viremia. They were all previously healthy. And then there have been 4 additional case reports through February of 2022 of this. At the same time, or right after, the UK started reporting, and they actually had a number of individuals, 111 cases of pediatric hepatitis, most of them less than 5 years of age. They had the typical kind of prodrome of gastroenteritis that you can see with adenovirus, but then it was followed by jaundice and marked AST, ALT elevations. And in the majority of those individuals, they also detected adenovirus. So adenovirus is a really common virus, but we don't typically see hepatic failure with adenovirus. So this is something new that we're seeing with a virus that has been around for a long time. In terms of the cases now, 169 hepatitis cases reported across 11 countries, most in the UK. 10% required liver transplant. There's been 1 death. And adenovirus is and adeno-associated virus are really the pathogens that are being detected. And then there was an alert issued, actually, by the CDC to test children with hepatitis, ALT greater than 500 of unknown etiology for adenovirus, not because there's necessarily a therapy that we can give for these individuals, but really to add to this, is this something that we're going to continue to see or not? Interestingly, the cases have sort of petered off, but in the time up until early August, we were still seeing more and more cases. In the US, since those early Alabama cases, we've seen 357 cases that are under investigation as being associated with adenovirus or adeno-associated virus across 43 states. So just something to be on the alert for if you do start seeing hepatitis cases. Again, these are not in adults, these are in children. And we've noticed that since June, the cases have decreased. Unclear whether there's a seasonal component to that, whether we'll see an escalation again, or if things have fizzled out. But I think the main thing is to monitor and be on this being on your radar if you do see children to test for this. Okay. All right, another case that I'm going to talk about is a 52-year-old man who presents with acute onset headache, nausea, vomiting, fever, muscle pain, and then he develops lower extremity weakness, and you note absent reflexes. The sensory exam is normal. What are people concerned about here? Guillain-Barré? Yeah, so polio, since this is an emerging infection talk, we've probably all seen the news last month, just about a month ago, that there was a case of polio in New York City, and after that case was detected, they did wastewater surveillance and noticed that it has been in the city wastewater. We don't know how long it's been in the city wastewater, and that suggests that it's circulating in the city and has been circulating. So this obviously is of concern. Even though this is a childhood vaccination, many of us have been vaccinated. There is concern for communities who particularly don't do vaccines. The gentleman who was diagnosed with polio, he was from a community that does not endorse routine vaccinations and has a pretty low childhood vaccination rate, on the order of just over 50%, compared to other communities which are well over 80%. So poliovirus, it's a human enterovirus caused by an RNA virus. This was clearly leading to pandemic, epidemic in the past prior to vaccine. And because it's an enterovirus, we think about it in the summer in particular, and in water, in terms of water exposure. So way back when in the 50s, there was concern about swimming, and kids weren't allowed to swim because of the concern for this spread of infection. And there was a lot of fear, and it was prior to COVID vaccine, I think it was the fastest approved vaccine in the history of vaccines because people were so concerned. Now, obviously, COVID beat that timeline for vaccines. But we do get concerned about this acute poliomyelitis that can develop. Nowadays, it's really not the wild type virus. There are very few places in the world that have wild type polio. So what we actually see is circulating vaccine-derived polio. So many years ago, the CDC Advisory Committee for Immunization Practices switched. There were 2 types of polio vaccine, and we switched from the oral live vaccine to the inactivated vaccine that's given by injection. And that was after many years and sporadic reports of transmission of vaccine-derived virus from patients who got the live vaccine to immunocompromised patients in particular, or unvaccinated folks who were exposed to shedding circulating vaccine-derived polio. So here is a map. The red areas are actually the wild type, and you'll see very few places. There has been a worldwide polio eradication program that's been going on. But the green is actually the circulating vaccine-derived polio that we're seeing. And so there's a number of hotspots in other countries that have the circulating vaccine type. So clinical manifestations: acute flaccid paralysis due to anterior horn cell injury, and they can be associated with symptoms of meningitis. And the weakness can progress. It's typically lower extremity and then progresses, so which is why, Guillain-Barré is a good thought and was probably on the differential for the gentleman who was diagnosed in New York, since we don't see polio very much in the United States. So in terms of where we are, as I mentioned, there's been a worldwide campaign to get rid of polio by 2026. It's just endemic in 2 countries, but we're starting to see the problem of this vaccine derived. So this is a huge barrier that we're seeing to eradicating polio. One of the things about the different vaccine types is that many countries are still using the oral polio vaccine because it's easier to deliver in some of those places than the inactivated type. But in terms of the US, as we see sharp declines in our vaccination rates, particularly among children, this is going to continue to be an issue. And in fact, in New York City, there are recommendations now to get a booster or to be vaccinated if you have not been vaccinated for polio before, just so because of the concern of the wastewater having polio and these cases this case in a relatively low vaccinated group. So I wanted to leave time for questions, but in terms of take-home points, there are lots of things on the radar that we hear, whether they fizzle out or not in terms of outbreaks. Like the tomato flu and other things we'll see. But right now, our main focuses are actually on monkeypox and COVID and potentially polio in terms of our preventative efforts, essentially. And if there's a vaccine for it, get it, because then that's our best way of preventing these diseases. Thank you. Yes?
What is the ratio of paralytic poliomyelitis compared to mild or asymptomatic infection?
Yeah, that's a good question. It's not. There are many people that can have mild infection, so it's relatively rare to have the more serious complications. I want to say it's on the order of less than 5%, less than 2%, but it's still a pretty serious complication that's preventable. Any other questions? Yeah.
What about those that received oral polio vaccine? Would you recommend revaccination? And second one is, what about travel to New York? Would you recommend vaccination for polio?
Yeah, that's a really good question. So if you've had oral polio vaccine in the past, you're considered protected. However, when people travel to more endemic areas and they've only had the childhood vaccination, it's recommended to get a booster. At this point, there's not a formal recommendation if you go to New York to get a booster, but it is something to consider at this point. I don't think it's a bad idea. Yes?
Do you think if we start to see more polio cases in the United States that there might be a consideration to change, you know how for vaccine requirements for students in school, they can no longer medically exempt from MMR? Do you foresee that being something as a possibility for IPV to medically no longer be able to exempt from it?
I think that's very likely a possibility. I think it's a tough balance between these mandates as we, think about more and more vaccines that we want to mandate. Particularly, there's a lot of pushback, particularly with COVID right now, and boosters and mandating. But I do think for kids, especially because this is transmissible, and we have a way to prevent it, that we could make some huge strides if we could treat it like MMR. And I don't think that there's the negativity with polio vaccine as there is with MMR. There's a lot of obviously misreports about the deleterious effects of MMR and autism that are unfounded, and there's nothing like that with polio, so I would hope that the uptake of polio vaccine would be better. I just don't think people think about it as a real infection that affects people anymore like it did in the 50s. Yeah.
I have a question if you can compare paralysis rates with wild polio and the polio we're seeing now that's mutated from the live vaccine?
That's a really good question, and I actually don't know the answer to that, just because we don't really see much the wild type anymore, but historically, I'm not sure. That's a good question, though.
I have a question regarding the monkeypox. Do we have a guideline or procedure on post-exposure prophylaxis?
Yeah, so if patients have been exposed and they're within the 14-day window, preferably within 4 days of a high-risk confirmed exposure, they can get the Jynneos vaccine, and then they should get the follow-up shot in 28 days. There's not really any other, we don't give antivirals for post-exposure prophylaxis. But they should monitor for symptoms, and actually they need to isolate or quarantine for 3 weeks is the recommendation, because that the incubation period can be so long, and so it's recommended that they get the vaccine, but they also isolate and monitor for symptoms.
How about medical professionals? If you saw a patient and then later they're diagnosed?
That's a really good question, because the CDC actually changed their risk assessment for monkeypox exposure. If you have a patient with suspected monkeypox, everyone should be in full PPE, which includes a respirator mask, eye protection, gown, and gloves. And if you are wearing those things, it's thought to not be a risk exposure. We have changed our practices at our clinic because I work in a clinic that is enriched for gay, bisexual, MSM, and we're seeing a lot of cases that we screen on entry to the clinic for any rash, and we just put them in isolation and until we can take a look at the rash and do the full PPE. And then if we think, oh, that's not it, then we can go about our business as usual, but just to have a higher level of suspicion for our patients up front. And then anytime you touch a rash, to wear gloves. That was actually one of the exposures early on in the hospital, that people were just touching this rash. And then there were a number of exposures from students who just wanted to palpate a rash, and unfortunately it did come back as monkeypox. So thank you so much.